I'm a neuroradiologist as opposed to a surgeon. I do diagnostic and interventional work. Today, we're going to be focusing on the diagnostic portion of that work. Obviously, imaging of the spine is an enormous topic, and I'm just really going to show you some highlights. I'm also going to point out a few anatomy tips and tricks, really. Obviously, you guys have been through, a comprehensive anatomy course, but here we're just going to focus in on some particular areas where some of the imaging modalities may be particularly helpful to relay the complexities and intricacies of those anatomic details, and to show the sort of technology that we have available in terms of our ability to show these technologies or to show these areas and pathologies to the best of our ability. So this talk is pretty much broken into two parts. The first part is going to be a discussion on, what is an imaging evaluation and where does that fit into the broader context of the clinical evaluation of a patient and patient management. And the second, and then a rundown on the various modalities of imaging that we have available to us, and maybe when you might want to consider ordering a particular test or referring for a particular test or using a test to guide either your clinical assessment or your preoperative planning or follow up on a patient. And again, that's very broad. I've obviously highlighted things that I think would be particularly pertinent to a neurosurgical spine surgeon, as opposed to all the imaging modalities that we have available in the radiology department. And then we'll look at, and then the second part of the talk will really be looking at some specific anatomy. And again, it's an enormous topic, can't really go through everything. And obviously I don't want to repeat what you guys are seeing, I'm sure, daily in terms of your textbooks and online learning and so on. So this is more like a guide and me just pointing out bits and pieces that I think are rather interesting and that you may want to pay attention to. And those areas are related to the cervical spine, the lumbar spine, and then a little bit at the end, being an interventionist on the vascular supply to the spine, to the spinal cord, just to give a sense of what we're able to see using angiography. And then at the end, I just threw in a handful of cases that I thought you guys might find somewhat interesting, just to kind of pull it all together. So first off, imaging evaluation, and I'm sure this is what you're all traditionally used to seeing. CT and MRI, cross-sectional imaging, makes up the bulk of our evaluation, and certainly the bulk of the imaging that gets performed for neurosurgical or spinal surgery patients. And you can see here the typical depiction of a vertebral compression fracture with some MRI and CT images.
Now, I've been using Grammarly for years. Now, the great thing is Grammarly is free and easy to use. It not only helps you check your grammar, but also ensures that your tone.
So how exactly does it all fit together in terms of you have a patient in the clinic or you have a patient in the emergency room, and most typical presentation is lower back pain. 80 to 90% of all Americans at some point in their lives will complain of a significant amount of back pain. So we're going to use that as our starting point, even though obviously, spinal surgery is a lot broader than that. But just using that as an example of how we think about when we would order a study, when we wouldn't order a study. Now, traditionally, and this may be a little quaint in this era, but traditionally, we would start off with so-called conservative management. If you read some of the old textbooks, I don't know if people even read textbooks anymore, but they'll say, give the patient 6 weeks of conservative management. You have back pain, go home, lie in bed, take some pills, maybe put on a brace, whatever it is. But you wouldn't even, historically do any imaging at all. Now, clearly that era has passed. Because And the reason they did that is, in the majority of cases, patients' back pain would resolve without incurring a lot of cost and without incurring any therapeutics with iatrogenics. But, again, we live in an era in which, we really use imaging. Imaging is really central to a lot of the management that takes place. And we can argue about, whether that's appropriate or not, but that really is the world in which we live. So radiographs would typically be a first step, particularly if you came through, for example, a family practice, unless, of course, you have a red flag. If you have any concerns that maybe this person has a neurologic deficit, if you have any features to suggest infection or neoplasm, or if you have a high level of probability based on their history that they may have a fracture, you want to speed this process along, and you want to get that cross-sectional imaging done. And really, MRI is our workhorse, and this is synergistic with CT. So as you all probably know by now, CT and MRI have complementary features and give us complementary information. Just in case you're wondering what these images are, in fact, I'll ask a quick question. What do you think this image is that I just showed you? This picture of a spine with a bunch of rib fractures. How do you think we got that picture? Anyone?
3D reconstruction from probably CT or maybe an MRI.
Correct. 3D reconstruction from a CT. And actually, this isn't your typical 3D reconstruction. This is what we call cinematic rendering. It's a new technology we have that actually allows us to depict our CT or MRI data in a photorealistic format. And I'm going to actually be using this quite heavily later on in the talk when it comes to looking at the anatomy, because this really allows us to see some of the anatomic details better than we would see on traditional radiographic evaluation. So look out for that. That isn't available everywhere, but that is something that I think will become more and more a part and parcel of everyday practice. And then, of course, we have options like bone scans, pretty good for looking for systemic issues. Does this person have multiple metastases? Do they have multiple fractures? Do they have a rheumatological condition with multiple bones and joints being affected? If a patient can't have an MRI, we typically use CT myelography. Historically, CT myelography was kind of a go-to, particularly for preoperative spine evaluation. It's being used less and less in the era of widely available high-resolution MRI. But it's always an option if for any reason a patient can't have an MRI. And then, depending on what we see on the MRI, we may perform additional studies to confirm or refute what our assumptions are. So if we believe that this person has a specific, particularly again pertaining to pain, if you have a pain etiology related to the facet joints or a particular nerve root resulting in radiculopathy, or potentially, again, controversially, people talk about discogenic pain or vertebrogenic pain, but discograms have kind of fallen out of favor to a large degree, but we can perform discograms, and we can also perform disc injections with steroids and so on to confirm or refute that as a sign of as a site of pain. Again, very variable depending on your institution and on the opinions of the people you practice with. But those are really the options, and that, broadly speaking, is the sort of algorithm that people tend to follow. Again, with CT and MRI really being the crux of most clinical practice. So obviously, starting with good old-fashioned plain films, and I think in this era we have a tendency to dismiss plain film radiography as maybe being old hat and maybe not giving us all that much information, but it actually is extremely useful. Firstly, because it's widely available, cheap, easy, low risk, and can depict very serious pathology. Certainly you can see fractures, certainly you can see any lesions that may be infiltrating bone. Obviously, we don't see the soft tissue very well. It is a composite image. In other words, you're taking a large volume of tissue and you're forming a single image out of that large data set. So because of that, there's superimposition of structures, which often can make seeing things quite difficult because you have overlying bowel, for example. The other thing, and I haven't mentioned this on the slide, but we can also perform dynamic maneuvers using radiography. We can perform those with CT as well, for example, but that incurs a much higher radiation cost. And those dynamic maneuvers often contribute significantly to your evaluation in the spine context, for example, for instability. In addition, particularly using whole spine radiography, there's several biomechanical features that can be assessed looking at various angles and orientations, which obviously is an entire discussion in and of itself. But as spinal surgeons, you'll learn all about that in residency, the various angles and contours that you may need to consider before performing particularly deformity surgery. And that predominantly relies on plain film radiography or some variant of plain film radiography. So CT, obviously, you start off with a plain film, and you now are able to not get a single superimposed image. You have a tomographic representation across a single plane with multiple slices, and this is a high spatial resolution. Spatial resolution is a term we use in radiology to say that you're able to depict very small structures. And you're able to see bone particularly well, particularly cortical bone. Soft tissue not as well, but certainly better than you would see on a plain film. And again, you know, the good thing about CT is, again, widely available. Most of you will have a CT scanner available. If not in your emergency room, immediately adjacent to the emergency room. Similarly, if not in the OR, immediately adjacent to the OR, probably. And so this is very accessible, very quick, has very few limitations as compared to, for example, MRI. And you know, limitations. It's not as good as MRI as we'll see in terms of soft tissue resolution. And in terms of the spine, it's not as good for marrow as opposed to cortical bone. So in terms of evaluating marrow pathology or marrow infiltration or marrow edema, you know, MRI really is the way to go. Now, bear in mind what I'm talking about here is sort of your standard run-of-the-mill CT and your standard run-of-the-mill MRI. You know, if you follow the literature closely, or if you work in a department where they're using very high-end scanners or high-end technology, you know, some of the things I'm saying may not be entirely accurate because of the advances in technology. But broadly speaking, for the purposes of this talk, I'm talking about the sort of technology that's pretty much available to everyone. So again, CT, again, depicting cortical bone very well. You have some assessment, as you can see here, of the trabecular architecture of the bone. For example, here you can see there's this infiltrative lesion. And just for orientation, you guys probably know you have your vertebral bodies, you have your pedicles, you have your posterior elements, including your lamina, and you know, the pars articularis going down here, depending on the orientation of the CT. What I wanted to show you here is that we can also take the data from the CT and actually use it for some very useful applications. We can do what's known as finite element modeling. You guys may be aware of, which allows us to, for example, compare population data with an individual's data and look at things like stress-strain relationships across end plates. And there are various software algorithms that are becoming more and more available in terms of assisting your ability to decide various characteristics of pathology. So for example, to make an assessment of whether a vertebra with a vertebral lesion, including a metastasis, is a stable or an unstable lesion. How would you guys typically make that assessment now? Do you think? Do you have any sense of how that's done? Determining instability in the context of a spine metastasis or a spine neoplasm?
With the SIMS score?
Exactly. The SIMS score, which is very helpful. But in addition, we can use some of the software to contribute to our decision making in terms of whether we think that a particular fracture is likely to occur if it hasn't already, or whether you're likely to have additional kyphosis going forward, and so on. And that's typically done using CT data and proprietary software. MRI, again, the strengths are mostly around its ability to differentiate different types of contrast. We have different types of sequences. Again, I think you guys will be aware. You may have seen the terms T1, T2, stir, flare, etc. And what these relate to are the specific parameters that have been applied in the course of acquiring the MRI. We use what are called radio frequency pulses, which measure energy at times of relaxation of proton spin. And without going into the physics too much, in terms of making these measurements, we know that different types of tissues have different measurements relative to one another. So looking at these individual measurements and forming a map of those measurements of the tissues relative to one another, we can decipher different tissues from one another. I said in terms of weaknesses, cost is potentially an issue. Again, in this modern era of trying to keep healthcare costs at a minimum, ideally. MRI is becoming more and more ubiquitous and more available. That being said, even if you do have several MRIs in your hospital, what you probably experience, depending on where you work, is that there are significant wait times to obtain an MRI. I mean, you can obtain a CT scan in under a minute, whereas an MRI with multiple sequences will take you traditionally, again, at least 20 minutes, and typically a lot longer than that because of the various requirements and evaluations that are needed to be made prior to performing the MRI. So it becomes a logistic and scheduling issue more than anything in the context of a hospital practice. And it's important to bear that in mind. So, oftentimes, the nasty radiologist will kind of call you up and say, hey, do you really need an MRI for this? Could we not just do a CT, or, can you not get by? Which is probably not something that you want to hear, but that's the explanation. That may change over the next few years with some of the new technologies that we have. If you're interested, you can look at things like compressed sensing, which is technology from the IT world, also called sparse data set evaluation, and that really allows us to accelerate the amount of or reduce the amount of time that we need to acquire a data of MRI. But again, just a traditional MRI, T1, you've probably heard of. We pretty much use this because of its ability to show us fat, and you may have heard the term "fat is your friend." So the fat that courses between the various muscle groups, etc., allows us to see structures immediately adjacent to it. So we typically use it for anatomy, because blood products also have specific characteristics on particularly T1 sequence. It's quite useful for showing things like hematoma. because marrow signal changes when you have infiltration, the typically intermediate signal of tumor becomes very dark. Therefore, it can be very good for looking for tumor infiltration. Now, T2 is really all about, if T1's mostly about looking at fat and blood, T2 is mostly about looking at water. Water, obviously, CSF being water, also water being edema. We often say tissue is stupid in the sense that, there are only certain things that tissue can do and can show you on a particular image. And that being that, it can either be the same as what it normally is, it can either be brighter than what it normally is, or it can be darker than what it normally is. And oftentimes that's not specific, but if you look across multiple parameters, you can often utilize that in order to come up with a good differential and hopefully come up with a specific diagnosis. The term, when T2, first came out, people spoke about this being a sort of a virtual myelogram. So instead of injecting the patient and doing a somewhat invasive procedure, you could do this non-invasively and really have a good view of the spinal cord, the nerve roots, etc. Because you have edema in the context of most injuries, this really becomes your workhorse sequence in terms of saying, is there injury to the disc, to the ligament, to the marrow? Is there bone bruising? Is there damage to the cord, etc. Gradient echo, and we have multiple variants on a lot of these themes. So again, I'm really showing you the basic sequences here. You'll see a number of variations. So for example, you might see a sequence that isn't labeled as T2, but maybe it's labeled as flare, or it's labeled as stir in the case of the spine. And what that is a T2 sequence which has been adjusted in a certain way to either remove fat or to remove the physiologic water. So the only bright signal you're seeing is from pathologic edema, as opposed to water from, say, CSF. But really just telling you what the basic fundamentals of these sequences are that you will see in everyday practice. Similarly, we talk about gradient echo or T2 star. Some people call this the hemosiderin sequence because it's typically good for looking for blood products. Some vendors have names for the newer, better gradient echo sequences, like you may have seen what's called a SWI, or susceptibility weighted sequence. I think GE calls it a SWAN, which is their own proprietary name, SWAN. But the long and the short of it is that wherever you have blood products or calcium, these things are going to show up better and brighter. Or actually better and darker, my bad. So the low signal, which is what we call signal dropout, that occurs when you have a substance which forms its own magnetic field around itself, gets exacerbated by this type of sequence. And it's kind of one of those things where, is it a feature or is it a bug? And it's a bug when you're trying to see details adjacent to, for example, metalware, and metalware is causing susceptibility artifact. But it's a feature when you can use that tendency of these kinds of materials to show you blood products better. So you may have a very small microhemorrhage, and you may see it better on a gradient or a T2 star or hemosiderin sequence because of that mechanism that I just said, if that makes sense. Traditionally, it was also quite useful to use for looking at the neural foramen. So if you look at this, these axial cuts, you have, the cord, you can see to some degree the nerve roots, and you can see the unconvertible spurring and the facet arthropathy contributing to the narrowing of the neural foramen. And on the traditional set of sequences, this would have been the best way to look at the neural foramen. This is changed to some degree now that we have very good high resolution 3D sequences that we can cut in multiple planes. But traditionally this was what would be used. Yeah, so high resolution, you know, we instead of using MRI sequences that cut through individual sections only, we're now able to acquire entire volumes of tissue, and then which is what we call a 3D sequence. And then you can take that volume of tissue and cut through it in any plane you like. The volumes of tissue, doing this in this way with these volumes of tissue also allows you to have a much higher resolution evaluation. So you're able to see much smaller structures, including, as I said, the neural foramen. We have a technique in MRI called diffusion weighted imaging. And you know, you may have seen this. You guys presumably have seen diffusion weighted imaging. Just yell out one or two areas where you may have seen people use diffusion weighted imaging, if any of you have, outside of the spine.
Hi, so I have seen DTI used for two things: for traumatic brain injury, and I've also seen it for tumors in the brain.
Yes,
absolutely. Interaction with white matter.
Yes, sorry, the question as maybe confusing you guys because the slide says DTI. DTI stands for diffusion tensor imaging. There are different types of diffusion imaging. More broadly speaking, diffusion imaging is any kind of imaging that will show you the passage of osmosis of water particles, and more importantly, where is that motion of water molecules restricted? A condition we call restricted diffusion. Can you guys think of any areas where seeing restricted diffusion may be helpful in the brain, for example?
Definitely seen it used looking for restriction in abscesses or
Abscesses,
strokes.
yeah. Very good. So differentiating abscesses which have hypercellular pus as compared to tumors which are not hypercellular. Yeah, that's one area where restriction.
Also for stroke,
exactly. Exactly. So yeah, in stroke, in acute stroke, particularly acute to early subacute stroke, you see restricted diffusion in the brain following the stroke. But just to put that in context, so the same technology is useful in terms of evaluating white matter tracts to some degree, because water will flow along the path of a white matter tract. It's flowing adjacent to those tracts rather than actually in those tracts. But we can use this tendency of water to follow those tracts to have a sense of the directionality of fiber tracts. Which is what is done here, and there are multiple different ways to do this. This is actually a fairly rudimentary example of just a clinical example in the case of an intraaxial tumor, and utilizing that to show that a portion of the tract is disrupted. Spectroscopy. I had a mentor who always used to say that MR spectroscopy is the modality of the future and always will be. I think that speaks to the fact that spectroscopy really has been around a long time, hasn't necessarily materialized in terms of its utility as a lot of people thought that it would. But in theory, you can differentiate different tissues and achieve a sort of a virtual biopsy. But in reality, it's used kind of infrequently as a problem-solving modality, and just kind of pulling that together. So, again, you have your T1 sequence with, you can see that, there's some sort of infiltration or some sort of abnormality of the marrow here. We have a stir sequence, which is a type of a T1 with bright signals showing where the abnormality is and which components of the bone are involved. And then we actually use the diffusion restriction here, which is quite useful for delineating or differentiating, and again, another example, differentiating benign from malignant vertebral compression fractures in this case. On sagittal section, again, you can see the fracture, not really much of a diagnostic dilemma, but you can see the edema on the stir, which is as I said, the type of a T2. you can see that the marrow is dark on the T1. And then we have these diffusion sequences, which in this case actually allow us to see that this is a benign fracture if we weren't sure. Then, like I said, you have a patient, you have a sense of where the pain generator might be, and then you might go on to perform a injection of some kind, typically with local anesthetic and steroid, which, our sort of anesthesia pain colleagues tend to use this as a therapeutic modality, and it can, in some contexts, be used for that purpose. But I think the greater benefit is really confirming or refuting a sense of whether or not a particular region or a particular structure may be contributing to the patient's presentation. Really quickly, nuclear medicine. Nuclear medicine is kind of the opposite of other radiologic evaluations. So, with the X-ray or CT scan, you take, radiation from the outside, it goes through the patient and you measure what's left. With nuclear medicine, the patient gets injected with a tracer, which contains the radiation and which is linked to a particular physiologic process. That then gets detected. So the radiation comes from inside the patient out and gets measured by detectors. Traditionally, we'd use technician bone scans for rheumatologic and orthopedic conditions, multiple fractures, as I said, or, multiple bone metastases is another fairly common indication. But this isn't very, specific. There are ways to assess what exactly you're seeing, on the basis of certain patterns and certain areas being involved. But in general, it can be quite hard to differentiate just, change from an arthritis or, spondylotic change from say a malignancy or metastasis. We have a much better version of this now available. Sodium fluoride PET CT probably doesn't get as much use as maybe it should in everyday practice. And there's also a cost consideration, obviously, but it's certainly better than traditional technician bone scans for looking for particularly bone metastases, or looking for multiple fractures, or looking for maybe subtle abnormalities. And you can see the difference here between the typical appearance of a technician bone scan and the typical appearance of a sodium fluoride PET CT, which is kind of the bone scan on steroids. And yeah, in both instances, you're really looking at bone turnover. All right, so that's really the first half of the talk. I don't know if you want to stop here and ask if you have any specific questions on that, or we can just move straight on in the next 25 minutes and talk about some anatomy. I think I'll just move straight on, if that's okay. So again, cinematic rendering, I think, is particularly useful for understanding anatomy. I think we're moving progressively towards an era where we're able to visualize things reliably in 3 dimensions with exceptional granularity. And we're also able to see with relative perspective where various structures lie adjacent to one another in terms of depth and position. And again, just to give you an overview of what we're capable of, you can see that we're able to pull back layers of tissue to depict muscle, and then to depict bone. We're able to look at 3-dimensional volumes in a comprehensive format from any orientation, in any obliquity. You can see how the individual structures really show themselves really well as compared to looking at a 2-dimensional image. And we can cut through, and we can look at individual structures that we may be interested in, or that may be relevant for a particular surgical approach. So
Complete your lung cancer diagnosis. Learn more at diagnosisstories.com.
So just to,
Sorry,
question?
I was going to ask just a quick question regarding this topic specifically, if that's okay.
Sure.
So I've seen this a lot on my rotations, and it's always been super exciting and super helpful. And just maybe from your perspective, a question I've always had is, can we totally rely on these 3D reconstructions for their anatomy? How accurate are they in your opinion? Like, can we depend on these things when we're thinking about surgical approaches?
Yeah, interesting. That's a great question, actually, and it's actually quite a complicated answer. So in order to answer that, I'll do that as best I can in the next 2 minutes. First of all, I think you need to understand how these images are derived, and I think by understanding how they're derived, that might give you a sense of how reliable they might be. So you acquire a volume of data, and if you think about the data in terms of tiny little blocks of we talk about voxels and pixels, right? So a voxel is a volume element of tissue. A pixel is a picture element. So the volume element of tissue corresponds to the picture element that you see on the screen, right? Now, each of those individual small little blocks that make up this large volume of information or this large volume of tissue can be looked at in various ways. Traditionally, when you look at a CT scan, you're not actually looking, again, in much the same way, you're not actually looking directly at the tissue, and it's important to always bear that in mind. You're looking at a computer algorithm's depiction of the tissue, right? Even in a simple CT scan, looking at an axial slice, you're looking at a depiction of what we call a sinogram, and the attenuation value is being rendered adjacent to one another and rendered in a certain format based on what the barriers of the tissue look like. But we know now, after several decades of using that type of imaging, that these are reliable, because you see the CT, you go to the OR, and you don't get a big surprise, right? So that's that. Then when you come to something like 3D representations, depending on on the specific vendor and the specific software, there is a different algorithmic approach to depicting the tissue. The value of cinematic rendering is the fact that what's actually going on is algorithms are plotting the trajectory, believe it or not, of thousands, in fact, tens of thousands of photons of light from multiple directions projected onto each and every voxel. And then the algorithm then takes all that information, all those trajectories of those photons, and it converts it into a depiction of the structures as you would have seen them if you were looking at a photograph, which includes considerations of like, where's the light being directed from, how much of a shot. I don't know if you guys do much photography or film or anything like that, but depending on directionality of light, depending on things like shuttering, depending on a number of parameters, you can actually depict these structures in various ways, which is what allows us to visualize the layers that we see. It also is what allows us to visualize the different depths and the shadowing of structures on top of one another. So the short answer after all of that is to say that, yes, I think overall this is an accurate representation of the anatomic structures. But I think you do have to be aware of the fact that there have been several layers of processing, and that the layers of processing are dependent on individual decisions as to how they want to depict various structures. Did that answer your question? Did that
Yeah, absolutely. And I'll say it's a very exciting part. I mean, I'm interested in neurosurgery, right? But like, I think the big future for the surgical approach is actually a lot of this imaging, because you can only innovate so much in the way you actually operate, but the way that you make operating easier with this type of imaging and similar is like a huge, exciting future for us looking into surgical specialties. And so it's really exciting. And it's good to know that it's, it's an accurate thing that we can use.
Yeah. So on that basis, again, very useful when you want to be aware of, for example, vascular structures. So you can see you have your common carotid artery, your carotid bifurcation, your internal and external carotid and the various branches, and you can see the vertebral artery here. And again, there are different ways you could render this. So you could render this in a way that shows the bones a lot more clearly, that shows the granularity of the surface more clearly, that shows the vasculature more clearly, or not. So it's important to bear, but again, that's what it comes back to your question. You could. So for example, if you were considering whether or not there's a small vessel coursing close to a tumor or something like that, you could filter that in or filter that out depending on the algorithm. And I think that's where a mistake could come in, not being aware of the fact that something is being filtered in a certain way. But I think overall the technology is reliable. Now a second a corollary to that would be, well, could we use this? Because when you say something's reliable, you kind of have to say reliable for what exactly, right? So if you were planning to use this, I mean, and we can go on various tangents, but just briefly, things like augmented reality or virtual reality, or using this as overlays in surgery. If you're looking at robotic surgery with anatomic trajectories to place your instruments, this is not going to be reliable. And this is not going to be reliable, not because the imaging is unreliable, but because the technology of overlaying imaging on physical objects is not reliable. I think I just throw that out there because what you'll probably see either now or over the next few years, a lot of vendors purporting to have technology that allows you to visualize structures directly over the skin, and in the majority of cases, that's actually not the case. There's actually a significant margin of error. The best algorithms that we've seen have been probably a minimum of 8 millimeters of error if you try to overlay digital information on soft tissue, particularly soft tissue where there's a lot of deformation in the course of a surgery. But anyway, that's a bit of a tangent. So what I wanted to show you here is, again, looking at a dorsal projection. This really shows you the posterior elements really well. You can see the spinous processes. You can see exactly what they look like. You can see if potentially there was an incomplete spinous posterior arch at a certain level, as we sometimes see congenitally. Again, getting back to being sure that you've actually rendered it in the correct way, that it's not a fabrication. The interlaminar space between the lamina, being able to see that really well to place a needle or to plan, for example, placing an endoscope. Those of you who may be interested in endoscopic spine surgery. And then, of course, your facet joints and the orientation of the facet joints from various angles. Here, I wanted to just point out a few aspects of the cervical spine anatomy. So people talk about some critical features of the cervical spine. So, as you know, you have the atlas carrying the world on his shoulders. Also, in biomechanics, they talk about the atlas as the cradle. Then you have the axis, which forms a pivot of rotation. Then you have the C2, C3 junction, which is a particularly important biomechanical component called the root. And then you have the remainder of the cervical spine, which people discuss as the column. Now, on these images, what I'm trying to depict is the fact that the odontoid process of C2 really fits really nice and snugly in the anterior arch of C1. And again, this depicts how, form really suits function. The ability to axially rotate about that odontoid process is facilitated by that. Another thing I wanted to show you guys, which I thought was quite interesting, was if you look at the individual vertebral bodies or the intervertebral joints, you have a convex superior margin, sitting inside a concave superior margin, and this really allows the individual levels to rock side to side. And then when we look at it laterally, you can actually see that at the level of the, and I don't know that I've depicted that as well as I could have, but at the level of the ancovertebral joint, along the side, you actually have the opposite. So you have a biconvex joint. So on the one side, you have convex inside concave, going superior to inferior. On the other, and looking laterally, you actually have concave into convex, which allows for anterior and posterior rotation. So it's a very clever mechanism, which you wouldn't necessarily seen without the 3D depiction. And here, just again, the atlas is called the cradle for a reason. You can see that this wouldn't be able to translate anteriorly and posteriorly, but it would be able to rock anteriorly and posteriorly and rotate within that convex margin. So you can see how you have a combination of flexibility and stability. Moving on to, and I see we have about 10 minutes left, so I'm going to go through the rest relatively quickly. Again, a projection from an anterior projection and an oblique anterolateral projection. I really wanted to give you guys a sense of what the neural foramini look like, where the new nerve roots are going to come out. If you look on traditional CT or MR, you often hear people talking about, oh, the neural foramen is narrowed because of facet arthropathy or facet hypertrophy or an unconvertible hypertrophy. And I never really quite, like, the unconvertible joints were always this sort of like this imaginary, magical place that I only heard about, when discussing, nerve roots on cross-sectional imaging. But I think this really gives you a good sense of what the unconvertible joints actually look like, and why having them being hypertrophied may actually contribute to the narrowing of those nerve roots. And how those unconvertible joints really do relate to the vertebral body itself, and again the neural foramen, and of course the facet joints at the back, and how their hypertrophy may contribute to the narrowing of these nerve roots. And again, by looking in different obliquities, you can get a sense of the actual trajectory of that neural foramen. I think looking on axial sections or on single cross-sectional sections, you tend to have a sense that the neural foramen just courses in one direction, and it doesn't really do that. You can see that it's actually a nice little tunnel that can actually lobulates over time. Here, a different rendering, and on this particular rendering, you can actually see the granularity of the surface of the bone, which I think for operative planning is quite helpful to have a sense of, okay, where could I actually realistically place a screw, for example, and how would that relate to the facet joints? In this case, you can see and this is an important, I think, anatomic detail, that the C2, C3 facet joint is actually orientated more medially than the remainder of the facet joints. And again, biomechanically, we talk about C2, C3 as being the root of the cervical spine, because of its ability to sort of maintain that position and maintain that lock between the Atlanta axial joints above and the column of the spine below, and not being able to tilt out laterally is part of that.
Dreaming of becoming a doctor? Make it a reality at the largest provider of new doctors to the US.
So just quickly, again, cinematic rendering, we can do this with MRI as well. This gives it a very almost cadaveric quality, I feel. I think that, back when I was a young lad, sitting in the Hunterian Museum in our medical school in Johannesburg, South Africa, looking at these plastinated or formalin soaked sections. They would take these cadavers and cut them in sections and place them in these awful jars that they'd leave in the museum for us to go through. And this kind of takes me back to that sort of sense of slicing through a real life specimen and actually seeing what the gross anatomy really looks like. I don't know if you guys get that sense as well, but that's kind of, or maybe that's just me being old and sentimental, or not, as the case may be. Again, depicting that in 3D, you can get a sense of where these structures lie relative to one another, and again some sort of depth perception. Again, I'm not going to go through all the anatomic structures, because obviously you all own textbooks and you all have a subscription to eAnatomy or whatever it is you use. But again, we can depict soft tissue structures very well on MRI. Here depicting individual ligamentous structures, anterior and posterior longitudinal ligaments, ligamentum flavum. Important point about the ligamentum flavum: it's not one long ligament. It's you have multiple ligaments interposed between the spinous processes. The dorsal soft tissues, the interspinous and supraspinous ligaments are important to be aware of. Individual muscle groups, we can depict those very nicely, again in 3D. I feel like if there's an area of anatomy you've never learned, it's always good to start with a 3D and kind of get a broad sense of what you're dealing with, and then working backwards. So you go from the 3D to the CT or the MR, and then to the plain film, which is kind of the opposite of what everyone learns, because the plain film is actually the most hard to understand, because it's the one most furthest away from reality, right? So you learn something in anatomy class in a 3D perceptual holistic environment, and then you kind of work your way back to cross-sectional imaging, and then work back from cross-sectional imaging to composite imaging like ultrasound or X-ray. Again, just more examples of how we can depict these individual muscle groups. Again, no point me, reading, teaching you how to suck eggs, so to speak. The lumbar spine, very similar situation. This is just an example, and this is one of the cases I was going to show you guys at the end of, augmenting a vertebral body with an implant and cement. Just showing you that again, we can go from the outer layers from a whole data set to depicting the 3D volume of the spine using this, in this case, using CT. Here you can see a vertebral compression fracture. You can see how this vertebral compression fracture contributes to the overall kyphosis. You can see the structures that are involved. You can see the trajectory of the pedicle. So if you were planning to do a percutaneous procedure, this would be useful to know. We can cut through, and I'll just stop there, for example, and you can see the individual facet joints, the spinous processes. If you were planning to do some sort of minimally invasive spine procedure, you can see how this would be particularly helpful. Again, the pedicle on the opposite side, the end plates. And you can also have a sense of just how osteopenic this poor guy was. He actually, after we treated this vertebra, he ended up fracturing this vertebra. We treated that, and finally got him on some anabolic bone agents. That's a top tip for you guys. If you see guys with, or people, men and women with osteoporotic fractures, please get them on the best possible osteoporotic medication as soon as possible. Again, just depicting, your traditional CT versus these volume renders.
What do you want? What a job that I don't hate.
MRI, again, we're able to depict our various anatomic structures very nicely. You can see the fecal sac. You can see the marrow of the bone really well. You can see the intervertebral disc spaces, and to some degree the degenerative process in the intervertebral disc spaces, spinous processes, interspinous region with interspinous ligaments, the individual ligaments that we saw earlier. Again, we can do this on cross-sectional view also. You can see the disc really well with the annulus fibrosus and the nucleus pulposus really better than we would typically see that. We can see the detail of the bone better than we would typically see it, including the trabecular architecture here. And we can see the individual musculature of the erector spinae. Starting to see the iliopsoas come in there. I'm not sure what level that was taken at. Again, this is kind of probably a bit different to the coronal sections you're used to looking at, but we have a good sense of what the vertebra, the intervertebral disc spaces look like, some idea of the degenerative process. And I think this really captures that better than traditional MR. Here, coronal section through the musculature with the erector spinae depicted here. And you can really see the fascicular nature of the musculature. Again, I think I don't know, do you want me to stop, or do you want me to just carry on for another 5 minutes or so? It's up to you guys.
You can finish up in 5 minutes. That's fine.
Okay, so just quickly, the angiography. I'm sure you guys know what angiography is. We use fluoroscopy, which is sort of X-ray movie. We place a catheter in individual vessels and inject and take pictures. And you guys during your neurosurgical training will perform angiography. We train the neurosurgical residents at our practice. It's becoming more and more of an integral part of neurosurgical practice, really, particularly if you plan to do any sort of vascular work. And this is just depicting, the level of detail that we can, first of all, you need to be aware of the individual structures, obviously the vertebral body or the corpus and the lamina spinous process, but then that allows you to know that you're dealing with pre-laminar branches and retrocorporal branches, for example. And we depicted these really nicely using Dyna-CT or tomographic CT using angiographic data. The artery of damkovitz is a key structure, and you recognize this guy because of the hairpin bend and its central placement. So here's the cadaveric section, and here's the angiographic section. It's very important in any spinal angiography procedure to be aware of where damkovitz is, and also where the other key, depending on the region of the spine you're looking at, some of the key, what we call radicular medullary feeders are. Here you can see the anterior spinal artery coursing down. The anterior spinal artery is supplied by multiple radicular medullary feeders in this sort of stepwise process, and you lose more and more of these feeders as you get older. This is showing you higher up at damkovitz, and then lower down these anterior spinal artery, which is contiguous all the way down, ends in what we call the basket, and the basket is contiguous with the paired posterior spinal arteries, which are also fed by radicular medullary feeders here, and that's just labeled on this section. This is just an example of getting faked out, thinking that you're seeing the damkovitz when you're not really, and different ways you can figure out what you're actually looking at. This is an example of a dural AVF, and just a reminder to more to angiographers to be aware that they need to look at all levels of the spine in order to try and find feeders for shunts such as dural arteriovenous fistulae. Just to show you that our technology is getting better at cross-sectional imaging. we can use CT angiography and MR angiography to depict a lot of these vascular structures, which were only really feasible using angiography. Nowadays, what we'll typically do if there's a clinical suspicion of, for example, a dural AVF, we'll perform an MRI and an MRA first. That often would give, well, not always, but probably the majority of the time when there is a dural AVF, we'll be able to see the feeder on the MRA. And then that will allow us to do a limited angiogram rather than doing an angiogram of the whole spine, which is obviously preferential for the patient. And again, using cinematic rendering, we can take the same data set and we can really depict the damkovitz really nicely, really depict these individual feeders supplying the anterior spinal artery. So you have anterior spinal artery, radicular medullary feeder, and then an additional radicular medullary feeder, this being the principal one, which we'd call a damkovitz. Just some more views of that. And the fun cases, I'll just go through in like 1 minute, just to show you guys. Here's an example of a spinal tumor, a hemangioblastoma, which we found on angiography, and just showing you the different ways that we can, render this. You can see how, if you were planning some sort of operative intervention, how it would be helpful to be aware of the various bony landmarks around the pathology. This, at the same time, it depicts the individual intersegmental artery that we've cannulated, and how the vessels come off that. Here an example of a dural arteriovenous fistula, and just showing that we can really render a depiction of the very tortuous, prominent veins that we see in the context of dural AVFs, and again their relative proximity to surrounding bony landmarks. I think this is just one more example of that. I think I showed you this earlier, example of a vertebral compression fracture treated with implant-assisted kyphoplasty. An example of maybe a little bit out of the spine in the pelvis, aneurysmal bone cyst, which was treated with internal fixation and repair, and required more than one surgery, and you can get a sense of where your hardware lies relative to the remaining tumor, and the remainder of the anatomy. So with that, thank you very much. Sorry I went over time a little bit, but I appreciate all your attention, and I hope that was useful.
Hey everyone, Ryan Rad here. If you like that video, subscribe and donate to keep our content available for medical students across the world.